Hello, my name is Dr. Joseph Mikhael. I'm the Chief Medical Officer of the International Myeloma Foundation, and it is absolutely my pleasure to just give you the rapid fire overview of the major themes of abstracts that were covered at this year's American Society of Hematology annual meeting in San Diego in December of 2023. It was an incredible meeting. 28,000 people were there in person. We had over 7,500 abstracts, over 1,000 of them dedicated to myeloma. So there's no way I can summarize them all. But what I'm going to do is just give you what I consider to be the major themes or the major areas that were so important that were covered at ASH this year. And perhaps the most exciting was frontline therapy. So initial therapy of myeloma. We had two critical abstracts, one in what we call the late breaking session, because it was brand new data that had just come out, and one in the plenary session where we select the very top abstracts in all of hematology. And both of them were studies that compared giving 4 drugs versus 3 drugs in patients who were going to an autologous stem cell transplant. So it was DVRD, or Darzalex, Velcade, Revlimid, dexamethasone versus just Velcade, Revlimid, dexamethasone, or the isatuximab or Sarclisa plus KRD, or Kyprolis or carfilzomib, Revlimid, dex versus just carfilzomib, Revlimid, dex. I won't get into the details, but the bottom line was giving 4 drugs versus 3 drugs was clearly better. Deeper responses, longer lasting responses. And this is really going to change what we do in myeloma, that really going forward, we now have different options, but generally we are going to be giving 4 drugs to patients who are going to autologous stem cell transplant. It wasn't covered at ASH, but we also know that there was a 4-drug versus 3-drug study in patients not going to transplant, the IMRAS study that we're going to hear a lot about in the near future. So that's section number 1, frontline therapy. Section number 2, screening for myeloma, question mark. We saw great updates from the iSTOP trial, the Iceland Screens, Treats, or Prevents Multiple Myeloma study, where we are learning, not yet ready for prime time, but building a framework that may ultimately take us to screening the general population to look for any evidence of early myeloma. We want to catch this disease early. Indeed, the delayed diagnosis is why a lot of patients run into trouble with kidney damage and bone fractures and things like that. And so we're not quite ready there yet, but amazing data coming out of Iceland. Section number 3, what we call early relapse. So in the setting where the disease unfortunately comes back after initial therapy in those first few lines. Historically, we use a lot of the same kinds of drugs that we used early on. Often we can add now selinexor to that mix, but there was some really great work looking at CAR T-cell therapy being used earlier in the disease course. Right now, we can only use CAR T-cell therapy after someone has had 4 prior lines of therapy. But now we're looking at studies when it was given earlier on, both with ide-cel, also known as Abecma, and cilta-cel, known as Carvykti, the 2 CAR Ts that we use later on. So very impressive data that when we use them early on, we get deep and durable responses, and that indeed they are better than the triplets that we typically use in that context. Section number 4 is late relapse. This might be the most exciting area of myeloma. Of course, there was a lot of talk about that frontline therapy, as I mentioned, but here is where we're seeing an explosion of new therapies. So if we look at the 2 major new therapies we've recently added, CAR T-cell therapy and bispecific antibodies, we're seeing kind of the 202 version of them. What do I mean by that? Well, with CAR T-cell therapy, as I already mentioned, we're using it, testing it earlier in the disease course, but now we're looking at ways to enhance CAR T-cell therapy even more. We're using new targets. Historically, we used BCMA, but we saw an interesting study using the target of GPRC5D, a new way of attacking myeloma in the context of a CAR T. We have got lots of products that are looking at faster CARs, the Arcelex program where we can give where we can manufacture the CAR Ts much faster than we used to. In fact, there are several products looking at this kind of fast CAR concept, but also looking at making the process safer, making the process easier for patients, moving towards doing it as an outpatient even, and making sure we manage those toxicities or those side effects of cytokine release syndrome and neurotoxicities and infections more effectively and more quickly. So lots going on in CAR T, but also a lot going on in bispecifics. really where we now have 3 approved bispecifics in the form of teclistamab, elranatamab, and talquetamab. And so we saw further studies using those, but we have a whole new set of bispecifics also coming. Some of them target BCMA, some of them target GPRC5D. We even have a new target, FCRH5. But what I was really impressed at ASH this year is the number of abstracts looking at how do we practically administer them in the clinic. Maybe we can give them less frequently and reduce the risk of infections. Maybe we can give them in combination. There was a couple of studies adding pomalidomide to it or adding daratumumab to them. Very interesting. And also not just bispecifics, but indeed trispecifics, where we can look at a drug that holds on to 3 things. So right now, bispecifics grab onto myeloma and to a local T cell to engage it. But there was an interesting trispecific that also held onto albumin, which is a normal protein in our body, to make the drug last longer in the system, kind of like an extended release. So really impressive work happening in bispecifics and lots of other new molecules, cell mods, and other things that are coming. Section number 5, health equity. You know, this is what I'm involved with very heavily at the IMF and our Empower project, but it was amazing to see how many abstracts were dedicated at health equity, demonstrating the link between the social determinants of health and our outcomes in myeloma, like income, like nutrition, like socioeconomic status, but also looking at ways that we can improve access to the therapies that we have, and indeed even clinical trials. A fascinating study called The Black Point of View, interviewing patients to understand their perception of clinical trials and how important it is for us to demonstrate culturally sensitive care and competent care in talking to our patients about clinical trials, because people want to be on trials. And we know that historically there have been underrepresentation of clinical trials from the African-American community, so patients with background like mine from Africa, but also Latino Americans as well. And so there's a lot of great work there helping us to understand this better. Section number 6, because I've got 7 sections for you. Section number 6 is what I call the patient-centric or patient experience. These were marvelous to see studies that really focus on the quality of life, the experience of the patient. Our own president and CEO, Yelek Baru, was an author on one of the posters that looked at what was the experience of the doctors and the whole healthcare team, of the patients and their care partners going through CAR T-cell therapy and experiencing one of the side effects known as cytokine release syndrome. So it's really impressive to see this, looking at wearable devices when people are being monitored for their potential side effects after CAR T or bispecifics. There was really a whole set of great abstracts that were dedicated to patients and their experience. And perhaps my favorite by my good friend and colleague Rahul Banerjee from Seattle was the down with Dex concept of looking at prior studies where people had a dose reduction of dexamethasone, and seeing if it actually had a negative impact on them, and it did not. We really can be using a lot less dexamethasone in myeloma. It's the drug that we love and hate because we know it helps, but we also know it causes a lot of side effects. So there was excellent movement in that realm. And lastly, section 7, we've talked about frontline therapy, screening for myeloma, early relapse, late relapse, health equity, the patient experience or patient-centric abstracts. Lastly, I would say there was great work on what we would call real-world data that compared what outcomes we see with the clinical trials, and it's great to see marvelous outcomes with clinical trials, but also what it really means in real life, and that often there is a big discrepancy. And so we have a lot of work to do to make sure that we bring these great therapies and apply them properly in the clinic so that patients can benefit. Overall, this was an incredible year for myeloma. I've been doing myeloma research for over 20 years. I've never seen a year quite like this year. Not only is there a huge volume of abstracts being presented at this meeting, we're kind of taking over the meeting as myeloma people, but we're really seeing progress that is helping both the quantity and quality of life of our patients. So we trust that this is going to have a greater impact over time as we work towards a cure in multiple myeloma. So there you have it, an extraordinary meeting, lots to experience in the myeloma world, from even before diagnosis right through to all the therapies that we give. Amazing progress, and I'm very thankful to be a part of it at the IMF.